Mutational testing is becoming more and more important in breast cancer, like it is in many other types of cancer now. The reason is that we now have actionable alterations and drugs that can target those alterations and improve the life of our patients with advanced breast cancer. The first one that was approved for mutation PI3 kinase mutation was alpelisib, and that's been useful in later line therapy after CDK4/6 and endocrine therapy. But now we also have the ESR1 mutation, which we understand conveys resistance to standard endocrine therapy or aromatase inhibitors. Fulvestrant is somewhat more sensitive to ESR1 mutations, and we're hopeful that the new class of agents, the oral SERDs, will show benefit in the ESR1 mutations, a common mutation that occurs after prior therapy. We also have other agents that are being developed in the PI3 kinase mTOR AKT pathway, and we have an AKT inhibitor, capivasertib, with very interesting results that may be approved in the near future as well. Finally, we have HER2 mutations, where we see those not uncommonly in 7 to 15% of breast cancer over time as the disease advances, and those patients may be candidates for TKIs and a combination of anti-HER2 antibodies and chemotherapy. Those studies are still ongoing. The one other piece which is very important for all advanced breast cancer patients is testing for BRCA1 and 2 germline mutations. We now know that if you have a germline mutation, high-risk patients will benefit from a PARP inhibitor, olaparib. Olaparib and talazoparib are approved in the advanced setting for patients who have a BRCA mutation. And in my own practice, if a patient has a BRCA1 or 2 germline mutation, I use PARP inhibitors after endocrine therapy, before chemotherapy. So it plays an important role. And although it's not necessarily widely recognized, BRCA1 and 2 mutations are found in hormone receptor positive HER2 negative breast cancer in 3 to 5% of patients. So that's the largest subgroup of patients, so a significant number of patients have that. I advocate all advanced breast cancer patients be tested for germline BRCA1 and 2. Our biggest challenges in advanced breast cancer is in the subgroup of triple-negative breast cancer because there is no, by definition, target against them. But where we've made substantial progress is with the use of immunotherapy in advanced triple-negative breast cancer that is PD-L1 positive. So what we found is that progression-free survival and overall survival is enhanced significantly by the addition of pembrolizumab to chemotherapy in the first-line setting of patients that have PD-L1 positivity. We've done, in the last year or two, a lot of fine-tuned work to figure out how much PD-L1 expression is important, and at least by the CPS assay, which is the companion assay for pembrolizumab, a level of 10% or greater conveys potential benefit to the addition of pembrolizumab. So that's 40% of patients who have a newer option for therapy. We've also learned that antibody drug conjugates play a role in advanced triple-negative breast cancer. Several years ago, we had the phase 3 ASCENT trial, which showed that sacituzumab govitecan improved both progression-free survival and overall survival compared to treatment of physician choice, any number of standard monotherapies with chemotherapy. So sacituzumab govitecan has become an important agent. This last year, we learned of a new category of breast cancer, HER2-low. And HER2-low refers to patients who traditionally would be negative by FISH testing, but 1+ or 2+ on immunohistochemistry. The DESTINY-04 trial enrolled patients with HER2-low. 90% of them were HR positive, HER2 negative, but 10% of the patients in that trial were triple negative patients and HER2-low. 1 plus or 2 plus by IHC. The benefit in that small group of patients appeared very similar to that in the larger group of patients, both in terms of improving progression-free survival and overall survival. So based on the data we have, which is a small subset, one could certainly consider testing triple-negative breast cancer patients after 2 lines of therapy to see if they are HER2-low and consider using trastuzumab deruxtecan in that setting, another antibody drug conjugate. And I think a lot of the future, at least of chemotherapy, will be using antibody drug conjugates in triple-negative breast cancer. That said, we're still looking for targets in triple-negative breast cancer, and we know that triple-negative breast cancer is a group of subsets which are not clearly defined. Some of them are immune-related, in which case the checkpoint inhibitors are of use, but there is those that are luminal androgen receptor expressing, which may have a totally different type of approach by using androgen agonists or antagonists. So as we ferret out the biology of triple-negative breast cancer, we'll likely start to develop better therapies because we'll understand targets, not just the absence of the 3 targets that make it triple-negative, ER, PR, and HER2.